Hello, this is Dr. Samuel. I want to talk in this video about the Caesarian section. You must have heard of it a lot, about people you know, women having it to be operated to deliver their babies. So, what is indeed the Caesarian section? It's a procedure which involves extracting the baby through the anterior abdominal wall through surgery. The baby will be, the anterior abdominal wall will be opened, the uterus opened, and the baby removed. Okay? It's the natural way of delivery, which involves the baby passing through the birth canal, through the vagina, and coming out into the world. So that is the Caesarian section. Okay? So there is why would so women have to have this through this method rather than the natural way? There are multiple reasons for that. First of all, there are two types. Some of them could be urgent, in which case you have an emergency Caesarian section, or it could be elective, whereby the need for section is foreseen during the antenatal period, during antenatal care, and then the section is planned ahead of time. So some reasons why a woman may have an emergency Caesarian section, which is the more common one, the emergency section is the more common type of Caesarian section. It's some reasons why it happens is that sometimes the baby's head is too big for the birth canal. I cannot pass through. Okay, so the baby's head could be normal sized, but the mother's pelvis is too small. The mother's birth canal is too narrow. Like some women who have an abnormal pelvis. Women have a kind of pelvis called the gynecological pelvis. It is shaped in a specific way, and it's very for the shape of a man's pelvis. So women have a pelvis that's like a man's pelvis, and it's not suitable it's not optimal for delivering the baby. Like a woman's pelvis, naturally, the gynecological pelvis, the distance from the front bone here, the pubic bone to the sacrum is widest. Okay? It's wide, okay? But in the man's pelvis, it's not so wide. So during delivery, for a woman who has a pelvis that's like a man's pelvis, the head can get stuck. Okay, so there are different diameters or measurements of the pelvis, and normal ranges for those measurements. But some women have smaller than normal. For some, more, all of the diameters. So you might have a small pelvis. Women of short stature. Short women usually have a small pelvis. Women who have had rickets in childhood will not have normal growth of their pelvic bones, so the pelvis can be small. Okay, so women who have had fractures in the pelvis, like during an erectile accident, may have a small pelvis. So the head of the baby may have difficulty passing, though it's normal sized. Also, sometimes the head of the baby is bigger than normal. You could have this in the baby you could have this when the mother is diabetic or develops diabetes in pregnancy. These babies tend to be bigger than usually. These babies tend to be big. Okay, usually more than the average baby, and those who have difficulty coming out through the natural method. So this is one of the reasons why a woman may have a Caesarian section. Sometimes the woman could have a tumor. There could be a tumor in the uterus in the womb, which is obstructing the baby's passage. There could be fetal distress, that's the labor has not progressed very properly, and then the baby becomes distressed, and the baby is not getting enough oxygen supply from the mother, and then baby's life is threatened. So this will call for an emergency cesarean section. The mother could be the baby could have a tumor, like something like a cystic hygroma of the neck, which is a tumor in the neck that obstructs the baby coming out. The baby may have an abnormally big head from too much of cerebrospinal fluid in the head, in the cranial cavity, and then this will cause the baby to have an enlarged head. That makes it possible to have a cesarean section. That is not natural delivery. There could be bleeding before the labor starts or during the labor. Heavy bleeding, that threatens the life of the mother or the baby during the labor process, and the labor will have cut short, and it's a section done to deliver the baby. So it could be because of the placenta being positioned the wrong way, like very close to the opening of the womb, or overlying it, okay, or even closing it totally. So, or it could be that the placenta separated ahead of time, ahead of the baby being born. So this threatens the baby's life and also threatens the mother's life, and a C-section is required in this situation. So these are examples of situations where a C-section is required as an emergency. For an example of situation where a session will be planned ahead of time, weeks ahead or months ahead, it's like if a woman develops diabetes pregnancy, or is diabetic and becomes pregnant. These babies will be expected to be, these babies usually could die very close to the end of the pregnancy, like at the 37, 38 weeks. The baby could suddenly die in the womb. So for the first reason, the treatment for this condition involves giving the baby by elective cesarean section at around 38 weeks. The normal pregnancy runs to 40 weeks. So for a woman who has gestational diabetes, the baby could be usually delivered at 38 weeks, 2 weeks ahead of the full term. Okay, so alright, so this is an example of an elective cesarean section, where an example of where an elective cesarean section is done. Okay, so those are examples of conditions requiring it. I've also mentioned a condition that's treated by cesarean section. It's called eclampsia. In this case, a woman who is pregnant develops hypertension, high blood pressure, and leaks protein in urine. And then this they tend to the risk of convulsion. So if the woman convulses, is called eclampsia. But before the woman convulses, it's called pre-eclampsia. If the woman convulses in this situation, her life is highly threatened and she could die. So the treatment for eclampsia is to deliver the woman by the fastest possible route, which usually is the cesarean section. So I have to mention that one too. So now, if your doctor tells you or your relation, okay, or tells let's hope you don't have to your relation that she needs a cesarean section, unless that's what she prefers. Or let's hope you don't have a cesarean section, unless that's what you prefer. Now, if the doctor tells a patient that he needs before the doctor decides the patient should be a cesarean section, you have to listen to the patient and hear any complaint the person may have, like the patient may say she's bleeding, or the patient may say that the patient may say that the pregnancy or the patient may come in maybe unbooked and complain that the pregnancy has gone on for too long. Okay, that's another reason for having a cesarean section. Okay, or the patient may come in and complain that the fetal kicks are reduced, and the doctor checks and confirms that there's fetal distress. Okay, or sometimes the patient is rushed in from another facility where they don't carry out cesarean sections, and we brought to the doctor where who does this, who in the center where stretches are done. So the doctor may hear that the labor has been on for too long, okay, or something, or so things like that. And then the doctor has to examine the patient, examine the patient generally, all the systems. That's the neurological system, the cardiovascular system, the respiratory system, the abdomen. The doctor will check everything up and then also examine the pregnancy itself. And then do a vaginal examination to check how the cervix is, whether how it's dilating, or whether it's or not, or how it feels. That means how short it is or not, and check the descent of the percentage part, like the fetal head, and see if it's coming down or not. And then based on all these, based on these assessments, okay, the doctor will now make a conclusion on whether the pregnant or whether the woman will get the pregnant sensation, or whether we like to continue, or whether we want to develop the woman naturally. So, and if the doctor concludes that you don't have a sensation, then you now run some investigations, so that pertaining to it, like when you want to screen the woman for HIV, to be sure to know that she has HIV, because it's taking the woman to theater. The operating room, they have to cut up the woman, and with much blood, with much bleeding, there will be significant bleeding, and that puts them. It's good for everybody to be aware of if the woman has HIV. The doctor's safety of other staff, and also for other patients who have to use the same, whom the same insurance will have to use, and then also for the patients who have interest too, so that the patient the doctor may watch out for complications that can arise because of HIV. Alright, so the patient will also be screened for hepatitis B, hepatitis C, and the urinalysis will be done, or sometimes urinalysis is done to screen for sugar in the urine. Okay, and then the PC, the past volume, or the hemoglobin concentration will be done to check for the amount of, you check for the you check if the patient has sufficient number of red blood cells or hemoglobin concentration to take the patient to theater. The patient who is anemic, who is anemic, will not be taken to theater without blood on standby for transfusion. Okay, so that's what the person's hemoglobin concentration will be checked. Okay, sometimes the person will need to be done with alongside the blood transfusion. So these things are tests that will be done. Sometimes the transfusion scan may also be done. Like if the doctor wants to confirm the status of the placenta, like if he wants to confirm for placenta previa or an aborted placenta, that's a placenta that's secreted before the time. If the placenta is separated before the baby is born, that's a crisis for the baby, because as you may know, the baby is sustained by the placenta, which is its connection to the mother. If the placenta separates from the mother before the baby is born, then the baby is left without oxygen supply, okay, and other nutrients. So then the oxygen supply and the glucose supply, if it's still cut off, and the baby cannot breathe, the baby will die inside the womb. So that's why that's the issue of an aborted placenta. A placenta that separates before the baby is born. Okay, for placenta previa, it's a placenta that is blocking the way of the baby coming out. It's blocking the way of the baby coming out. So for the baby to come out, the baby is going to separate the placenta, because the placenta sits in front of the baby, ahead of the baby. So that's what to say. So the baby will have the placenta will have to separated by the baby's motion of coming out. Okay, or the contractions. That was the contractions one not deliver the baby, also deliver the placenta ahead of the baby. Okay, so there's a lot of usually bleeding involved. So the parental picture will have to be, so they don't have to do a scan, ultrasound scan to be sure, to assess the status of the placenta. Alright, so now, if after the doctor has concluded that the lady is going to have a cesarean section, the lady now be prepared for a cesarean section. This will involve shaving the pubic hair, passing the urethral catheter, because after the cesarean section, it's quite painful for a lady to chance mobilize herself to pass urine because the big wounds that the process involves on the abdomen. So it kind of helps to empty the bladder passively and continuously. So the one doesn't need to pass urine. And then also passing the catheter helps to make the doctor observe how much urine the patient is making after surgery, because that's important. If there is too much blood loss or too much or low blood pressure, so the patient will not make sufficient urine, and that's a big problem. The patient will not make enough urine. He has renal failure, acute renal failure, which quickly leads to death in a few days. So that capacity helps a lot of assess how much urine the patient is making, and then also the catheter also deflates the bladder, because when the blood is working inside the abdomen of the patient is very close to the bladder. So the catheter drains the bladder and makes the volume of the bladder low and small, so it doesn't obstruct the way and reduce the risk of injuring the bladder during the procedure. So the catheter will pass from the patient before the patient is taken to the theater. Okay, so after the operation is done, then an IV line or IV lines, sometimes 2 IV lines are set for the patient. These IV lines as venous access are done so that an infusion can be run during the procedure. The infusion is meant to replace blood loss, volume loss, because the session involves bleeding. So that having an infusion going on replaces some of the volume that will be lost during the procedure. Okay, it's directed to help to counter the volume of blood that will be lost during the procedure, and the line also used to give drugs. Some of them are called pre-medication. Some drugs are given before surgery to prevent maybe the patient secreting too much mucus and then aspirating it into the airway. So a drug is used to that purpose. So another drug is used to prevent the patient vomiting. The patient who vomits during the procedure is a crisis, because if the patient are breathing the vomit to the airway, it will cause a condition called aspiration pneumonitis, which is also very serious. Okay, so because of the acid and the enzyme, the acid and the enzyme in the stomach, the gastric juice will now damage the patient's airway, and then because the bacterial content of the stomach, maybe from food, okay, an organic bacteria in the stomach, that will quickly cause an infection in the airway, which is very, very serious. So no doctor wants to have a big patient who was raised during surgery. That means that's crisis. Okay, so the drug will be given to prevent vomiting during the procedure. And also, for emergency section, it's not pre-planned. So often the women who are taking the theater already have eaten. For elective section, the patient will ask not to eat overnight before the surgery is done, to enter the stomach and reduce the risk of aspiration during the surgery. Okay, so a drug is used to prevent the patient vomiting during the procedure, and then sometimes blood will be given through the IV access. Then the procedure the procedure itself, the patient will now be taking the patient will observe a few things. The patient will observe the doctor there and his assistant, and then some nurses too, and another theater staff who are there to participate in the procedure. The patient also will observe instruments on the tray, may observe drainage like a social machine, may observe an oxygen cylinder, may observe a respirator or a ventilator, may observe so the patient may observe a ventilator, or may also observe the lights of the theater. Okay, they are usually not the lights people are familiar with. It usually has a big disc, white disc that's about the meter wide, with many lights in it. So the patient may observe those lights too, and then the patient will be cleaned with a Savlon and methylated spirit. So the methylated spirit is cool. So when the patient is cleaned with it, the patient may feel the cool sensation. Okay, and since the patient was recently shaved, spirit on the first one is painful. The patient may feel some pain from the spirit touching the wound from the freshly shaved skin. And then after that, after the shape is done, after the clean is done, the patient will be draped with drapes that's some cloth material are placed on the patient. They are meant to cover all the places that are not part of the surgery. Only so that only the area that's going to be operated on is exposed. This helps to prevent bacteria spreading to the wound during the procedure. So the patient will be draped. So that's about the last thing the patient will see. The draping procedure, and then the anesthetic will be given, and the patient will go to sleep. So after the patient goes to sleep, then the surgeon or the doctor will now begin the procedure, which will involve checking the level of anesthesia to ensure the patient is not feeling pain, and then make an incision, cut the skin. It is usually the skin will be cut over in the lower part of the abdomen, just above the hairline. It will be hairline, or it will be cut. The patient will be cut in a vertical incision below the umbilicus, below the navel, vertically. So the one that the incision that is invoked now is the one that's parallel to the head, the big hairline. So the incision will be cut and then deepened. There are 6 layers to cut. The skin is cut, the subcute, that the fatty tissue under the skin, which is actually technically part of the skin, is cut. Then the fascia, this is thick, strong layer, is cut. Then the muscle, that's the rectus muscle. There are 2 of them, 2 rectors, they are separated. Then the peritoneum is the transparent layer, or which is the last layer before you enter the peritoneal cavity, that is the space of the abdomen, is also cut. And then the uterus will be exposed. Once this is cut, the uterus, the big enlarged wound will be seen. And then that is also cut. That is cut in a transverse fashion. Before, earlier, it was done, you cut vertically in the upper part of the uterus, but that's prone to rupturing during the next pregnancy. So, or during subsequent pregnancies. Okay, so to prevent rupture in the because that tendency to rupture in the subsequent pregnancy, the uterus will cut. Usually now it's not cut in the lower segment, that the lower part of the uterus, that's a thin part. During labor, the lower part of the uterus will thin out and become very thin. It's part of the effacement process. That means the surface will shorten and become softer and softer until it now and also widen until it now fits around the head of the baby and now passes beyond the head of the baby. Okay, passes beyond the top of the head of the baby. So that during labor, the cervix, which is the lowest part of which is the neck, or you can say the mouth, which is we call the mouth of the womb, which is thick normally, will thin out, become soft and shorten and continue to shorten until it's completely shortened, and then it will be widening up and until it's fully wide, 10 centimeters wide, and now the baby's head and can now fit around the head of the baby, with more contractions, the baby's head will now slip through. So the baby is only delivered during the normal delivery or the vaginal delivery when the doctor cannot feel that cervix anymore. If the delivery is attempted while the cervix is can still be felt, it will tear. If it tears, it will bleed a lot. Okay, and the breast can put the woman and the baby will patient and so this thinning process also happens to the lower segment, at the lower part of the womb. The rest of the womb also thins out too. So cutting it during a cesarean section involves less bleeding than if it was fully thick. But it also bleeds. It can bleed quite a lot. So this to the uterus is cut in the lower segment, and then the uterus will encounter the membranes. That's covered the membranes of pregnancy. That contains the amniotic fluid in which the baby is floating. So the membrane will now be ruptured, and the amniotic fluid will gush out. The next thing will be to bring the baby out. So usually the baby will be brought out by taking the whole of the head, and then with some fundal pressure on the upper of the abdomen, the baby will be delivered. But sometimes this is usually necessary when the incision is done near the hairline. It's usually difficult to deliver a baby just by the head without assistance at the top of the abdomen. But if it's done, if the procedure was done with the vertical incision that's under the liver, you don't really require pressure from the fundus of the uterus. Okay, so after the baby is delivered, the next emergency is the next urgent thing to do is to stop the bleeding, because you cut the uterus. The uterus is a very big muscular. The uterus is a very muscular organ and bleeds a lot. So and the pregnant uterus is enhanced to bleed to transmit to conduct blood because of the baby that's inside it. Because it has to sustain the baby, so it bleeds a lot. So now the next thing is to stop the bleeding. So there are methods that are done to stop the bleeding. The edge of the wound are clamped with something called green hermitage. It's used to clamp the edge of the wound, and then also oxytocin is a hormone. It's a natural hormone that drives labor. It's given to the woman. That's from outside, from the exterior. It's augmenting that of the intrinsic one in the already to cause the uterus to contract. So when the uterus contracts, it now compress the arteries in the uterus and stop and help stop the bleeding. So this hormone is given. The hermitages are applied, and then the next thing will be to clean the cavity of the uterus. This is done, and then finally to take full care of the bleeding. The wound is repaired. The cut is repaired in layers. Okay. When the repair is done, the doctor will check and be sure there's no bleeding points left, because you can't close an abdomen when there's some bleeding. The baby can bleed on after you've gone. So the wound is checked for bleeding for any bleeding points, and when the doctor is satisfied there's no more bleeding, you now start to close the abdomen again. You now repair the abdomen again in layers. But the reverse, the way you go out, the reverse way you came in. So now you will now close the peritoneum. Some doctors don't close that in these days. Now oppose the recti closer to the usual as before, as it used to be. Repair the fascia. The fascia is the strongest part of the abdominal wall. That's if it's not repaired, the patient will end up with the hernia, an institutional hernia. So when the patient after the procedure and the patient is discharged, if the patient sits up, there will be a bulge where the operation was done before. If the patient coughs, there will be a ballooning where the operation was done before. So the patient has to be closed very well, so that's what happen. And then after that is done, the subcutaneous layer, which is the fatty layer, will now be repaired, and then the skin will be repaired. And if after this is done, the patient, the wound will be dressed, the patient will be cleaned up, because usually, as I said before, it's a bloody operation. Usually quite significant bleeding. So the doctor will now clean up the patient, clean up all the blood, and then clean up the vagina too, because the bleeding, there's no bleeding through the vagina. Clean up the vagina, and then apply and put in a drug called misoprostol. It's a drug that helps keep the uterus contracted. You put that in the rectum of the patient. So that will keep the uterus contracted for after the immediate postpartum period, after the patient has gone to the ward. So that's where during the recovery, that the drug will be in action to keep the uterus contracted. And usually the uterus will be contracted to keep the arteries of near the wound closed, compressed, so that it doesn't bleed, and also to keep the uterine bed itself, where the placenta was removed from, not to bleed, contracted. The muscle will be contracted. The muscle underneath that where the placenta bed will be contracted and prevent bleeding. So when this is done, this is now maybe the patient will now be after the cleaning and application of the misoprostol in the rectum. The patient will now be moved out of the operating room to the recovery unit. So that's part of the care that will happen is the patient will not be allowed to eat or drink until the bowel sounds that are heard. Bowel sounds are the sounds that are heard in the stethoscope when the intestines are contracting. When during the operation, when the intestines are touched with the hands, they stop moving. They stop moving. So it takes a few days, 1 or 2 days usually for them to start moving again. And if the intestines are not moving, it means they cannot conduct food material. So if the patient eats the food will not move, and the patient will bloat. The abdomen will bloat. So because of that, the patient will not be allowed to eat. So because the intestines are not working, the intestines are not moving. So the patient will not be allowed to move until the patient will not be allowed to eat until the intestines have been confirmed to have resumed movement. So the doctor usually will do that by checking the stethoscope on the abdomen to hear the sounds of the intestines moving. Sometimes before the doctor has done that, sometimes when the doctor does that, the patient will come. Sometimes the patient will come, will pass fluids that pass gas through the anus before the doctor even comes for a ward round to check, like on the second day, to check if the virus has returned. So the doctor will volunteer that they say that she has already passed gas or even gone to the toilet, and then the patient will be allowed to start taking food through the mouth. Okay, so and then the purpose of the care after the operation is antibiotics will be given to prevent infection of the wound, to prevent infection of the wound, and then the patient when the patient is not eating, the patient will be getting calories and fluids through the vein. So drips will be given to the patient continuously all through until the patient can take oral again. So what problems can arise from the Caesarian section? These days, even a possibility in most Caesarian sections in the developed world are done through spinal anesthesia. That means the patient is not put to sleep, but the lower part of the body is anesthetized with an injection into the spinal canal, into the vertebral canal, which contains the spinal cord. Okay, so this when the injection of anesthetic in this canal will now numb the nerves that pass beyond that point in the vertebral column. So that is what was invoked now in developed countries. So the mother will be aware and awake during the procedure. Those should not be able to move her limbs during the procedure, and will not be feeling pain. Okay, so this has an advantage. There's an advantage. It has an advantage that the patient is not going to sleep. and the risk that attendant will put the patient to sleep will not be there. Although putting the patient to sleep is not a very risky thing actually. It's not a very risky thing. Most patients who are put to sleep wake up, get back up without any problems. So after and also spinal anesthesia has its own problems. It can usually it may be followed by severe headaches. Okay, because of changes in pressure, running of the pressure in the cerebrospinal fluid. So it could really cause, there could be serious headaches, there could be sensations, the anesthesia could cause residual paresthesia or normal feelings that are very disturbing to the patient. Sometimes even there could be if the anesthesia, if the anesthetic goes upward to the thorax and knocks off nerves that supply the heart and lungs, there could be serious issues like the blood pressure of the patient collapsing. So this is an issue with this. So that will lead to death. And then also the procedure, also so before a spinal anesthesia is applied, the patient will be charged with fluid to check the blood pressure in anticipation of a collapse or a reduction when spinal anesthesia is given. Okay, so if that charge with fluid if the artery is not done, when that spinal anesthesia is given, the blood pressure will drop to abnormal. I've seen a case where it dropped to about 60. The systolic dropped to about 60. Okay, and then the patient had to the patient had to be stopped until enough fluid had been given to the patient to raise the BP again. So this is usually done. The fluids are usually charged into the patient to charge the word charge is used. I use the word charge to increase the blood pressure, to raise the blood pressure, so that in anticipation of a collapse or a reduction when the anesthesia is applied. So, but so the procedure also has its own problems too that can arise from it. The spinal anesthesia. So in this part of the world, especially in this country, okay, most research are done with using general anesthesia. All right, so now after the patient has passed physics or the body cells have been held, the patient can now begin to eat. The antibiotics will now be changed from intravenous to oral antibiotics. So what problems can arise from the cesarean section? One, there could be excessive bleeding during the cesarean section, because and then that require a blood transfusion for replacing of the blood loss. Okay. So apart from then also you could have an infection of the wound. The wound can become infected and does not heal normally and within the expected time. And so you have pus in the wound break down, and the wound may have to be cleaned again, dressed again for a while, and then the person is taken back to theater for a secondary seizure, a secondary closure of the wound. Okay, sometimes the patient will not be taken back to secondary closure. The patient may have to dress it until the wound heals. Okay, so even if this doesn't happen, if this doesn't happen, and everything's alright, the patient usually may be sent home on the 5th day after the procedure. Okay, sometimes earlier than that, sometimes even the 3rd day after the procedure, the patient will go home and then come back for the checkup. Okay, all right. So that's how a cesarean section procedure goes. Yeah, apart from a wound being and a wound breakdown, you will not you don't think that if a woman has had 2 previous cesarean sections, all subsequent deliveries will be by cesarean section. So if a woman has had 2 previous cesarean sections, all subsequent deliveries will be by cesarean section. So that's how it is, and that is it for a cesarean section. Thank you very much.